I want to thank Suna for inviting me here to speak. I think Lori has been asking me to speak for the last 5 years. Unfortunately, this time of year falls around one of my anniversaries, or my anniversary. So it's always been. I only have one wife. It's always been tough to make it here. So I'm glad we were able to do it this year. So thanks, Lori. It's a pleasure to be here. I think it's great to be speaking in front of urology nurses. You know, in our practice, we really value our nurses. And I have a great anecdote. We were driving during a family trip. We were in Traverse City, Michigan this year, and I went to an Ace Hardware store. We were gonna glaze our Petoskey stones. And so I went to go pick up some stuff to sand our stones. And the clerk at the Ace Hardware, we're talking, and she's like, "Oh, where are you from?" And I said, "Chicago." And she's like, "Oh, I used to live there." And she was actually a urology nurse at Loyola. And she'd retired and then moved. But she was so excited to meet a urologist. And she like held me up, and then she called her husband. She's like, "Phil, come here." And then, you know, we talked for like 10 minutes, and my wife and kids were waiting in the car. But I could, you know, there's just, it's a special field, and you guys are special nurses, and you guys understand urology from a very special viewpoint, you know, besides any other nursing field. And so I think there's a reason why nurses stay in the field. They're not moving over. And I know we've had a lot of new nurses that come in, and they've been there for years, and they stay as urology nurses. It's a great field, and I'm excited that you guys are here, so thank you. Today my topic is renal and bladder cancer update. It's a pretty broad topic, so I selected a few things from each of those cancers to talk to you about, and then certain things pertaining to nursing. So we're going to go through some renal cell carcinoma staging, management of localized disease. I understand you're going to have a talk later with chemotherapy, so I'm going to minimize the metastatic disease management. We're going to talk about one change that pertains to surgery that's up and coming, but not going to talk too much about that. Bladder cancer staging and localized management as well. So with renal cell carcinoma, there's approximately 64,000 new cases each year. It's the 6th most common cancer in males and the 10th most common in females. So you can see the male to female ratio. It's higher in males, about 3 to 2. And the estimated deaths account for 1 to 2% of all cancer deaths. And approximately a half nowadays are diagnosed incidentally with imaging. Some of the risk factors for RCC, people may not know this, but the most common risk factor for renal cell carcinoma is smoking. So it's not only for bladder cancer, but also for renal cell carcinoma. It has to do with the carcinogens that are transferred from the bloodstream, and then the kidney filters them out, and that's where the carcinogens may stay and cause the mutations that can cause renal cell carcinoma. Obesity, hypertension, chronic kidney disease, there's genetic causes, and then a lot are unknown. There are still a lot of unknown risk factors. We have mechanisms and genetic mutations that we've studied that can develop into renal cell carcinomas, but as far as what is causing those, there's still a lot of unknown risk factors. The majority of renal cell carcinomas are found with patients that are asymptomatic. So these are your patients that have gone into the ER, or their primary care doctor had either renal imaging or a CT scan for some other reason, and they were found to have a renal mass. And that's the good news, because most of those patients, these tumors are localized and they're smaller and very manageable. If you have symptoms, or if patients have symptoms like flank pain, hematuria, abdominal masses, anorexia, hypertension, anemia, these are usually signs and symptoms of later stage or more advanced disease or locally advanced disease. So it is nice that a majority are asymptomatic at diagnosis. The initial evaluation, so if you have a patient that's going to come into your office with a renal mass that was found on a CT scan that was maybe non-contrast for a kidney stone analysis or evaluation, you're going to do a history and physical examination, laboratory studies, CBC, and a chemistry panel, urinalysis, and then there has to be some type of axial imaging, an abdominal pelvic CT or MRI, and it has to be contrast enhanced. It's really important to have these patients get a contrast-enhanced CT if possible, if they don't have chronic kidney disease, because that enhancement does help us with the diagnosis and characterizing the renal mass. For patients with certain renal masses, if clinically indicated, a bone scan a brain MRI or a chest CT may be indicated. And then there's always a consideration of a needle biopsy for larger masses as well as smaller masses. Smaller masses for active surveillance or watching some of these patients. Larger masses because there may be clinical trials that these patients may be eligible for, and having tissue beforehand is important. This is just a diagram of the staging for renal cell carcinoma. Most of you may be familiar with this. Stage 1 is any tumor that's less than 7 centimeters. So it's divided into T1A and T1B. T1A is less than 4 centimeters, and T1B is between 4 centimeters and 7 centimeters. So these are tumors that can be up to 7 centimeters and are localized to the kidney tissue itself. The stage 2 tumors are greater than 7 centimeters in size. They are still, however, localized to the kidney. So they may be larger than 7 centimeters. They may have central necrosis, but they're confined to the kidney capsule itself. Stage 3 tumors, these are tumors that are now more locally advanced. So they've advanced through the capsule of the kidney and they're invading into the perinephric fat outside of the capsule. The renal sinus fat as well is considered a stage 3 disease and T3 disease. And if they have renal vein invasion or IVC invasion, that's considered stage 3. And as most of you know, stage 4 disease is any disease that's metastasized to surrounding organs or distant organs, as well as the lymph nodes. It's important to know the stage, as this does help with prognosis and survival. The stage 1 tumors, for the most part, the 5-year survival is 95%. So localized disease is very controllable, very curable with durability. Stage 2 tumors, they can be more aggressive, and the 5-year survival drops down to 88%. With stage 3, you now have more advanced disease, and these are the patients that may need adjuvant therapy, and now in clinical trials, maybe even neoadjuvant therapy. But if they have any one regional lymph node involved, it makes them stage 3, and the 5-year survival is 59%, it drops off. And as you can see, for stage 4 disease with distant metastases, your 5-year survival drops down to 20%. When you look at the American Cancer Society survival rates, for localized disease, again, the 5-year survival for low risk is 97%, 81% for intermediate risk, and 62% for high risk. So why for localized disease, for high-risk patients, can you have lower 5-year survival? Where there are changes in aggressive cancers that may be small or localized, such as sarcomatoid differentiation, and these are considered more aggressive cancers, and even with small renal masses, these cancers can metastasize. So that's one of the reasons. Smaller centralized tumors that start from the center of the kidney, they can invade into the renal vein and the vasculature as well as the lymphatics of the kidney and spread faster because they started out near the center of the kidney where there's bigger vessels and bigger lymphatics. And so that's why with these higher risk patients, you can have a lower survival rate. With metastatic disease, you can see the lower survival rates, 41% for low risk, 18% for intermediate, and 8% for high risk. So according to the NCCN, and this is all based, this part of my talk is now on NCCN guidelines for the management of renal cell carcinoma. If you have stage 1 disease, which is localized to the kidney, your options can include partial nephrectomy, and that's removing the tumor and saving a portion, a significant portion, or even a smaller portion of the kidney for renal preservation. Radical nephrectomy, which is removal of the entire kidney, the fat around the kidney, a portion of the ureter, and in some cases you can remove the adrenal gland if the kidney tumor is adjacent to the adrenal gland or if it's directly invading. A lot of times now with lower pole tumors or tumors that are away from the adrenal gland, we're preserving the adrenal on that side. And then active surveillance. This is also indicated for localized tumors because certain patients that, again, these tumors may be smaller and certain patients may have significant comorbidities where actual treatment of these tumors or the surgeries may not benefit their quality or quantity of life, and therefore there's a select group of patients, usually elderly with multiple comorbidities, where we can watch these tumors. And in these cases, biopsy is indicated. We can biopsy the masses to find out what kind of cancer it is. We can even grade the cancers now with biopsy, so you can get either a low grade or a high grade, and that might help dictate what you do in the future for these patients, whether you're going to survey them closer every 6 months or every year imaging, or if you're going to proceed with treatment in the future if they grow. And ablation is another option for localized stage 1 kidney tumors. Typical tumor size for ablation is less than 3 centimeters, and ablation can occur either percutaneously or laparoscopically. And the methods of ablation are radiofrequency ablation, which is heat energy that burns the cancer cells in the tissue surrounding, or cryosurgery, which is actually freezing the tumor cells, very similar to placing, I tell patients it's like placing a can of Coke in a minus 20-degree freezer, where the cell wall, which is the Coke can, will burst. And so that's a direct cell kill mechanism of cryosurgery. And again, these can be done percutaneously, so in a minimally invasive approach through interventional radiology, or through a laparoscopic approach the urologist will sometimes employ. For stage 2 disease, a radical nephrectomy moves to the top for larger tumors, so certainly ones that are more centrally located. Radical nephrectomy is indicated. Partial nephrectomy may be indicated in certain large tumors that might be exophytic or more towards the edge of the kidney. And then again, there are ongoing clinical trials now with patients with stage 2 disease. So with current immunotherapies, which I'm sure you're going to hear about in your chemotherapy talks, there are now neoadjuvant immunotherapy trials where we're giving patients a course of immunotherapy following their imaging, and then following that with a surgery, either a radical or a partial nephrectomy. So these are ongoing trials to see if we can decrease that risk of recurrence and improve the survival in these patients. For stage 3 disease, radical nephrectomy is the therapy of choice. Again, partial nephrectomy may be indicated in certain patients. Sometimes we do partials for exophytic tumors, and there might be a localized area that's invading the fat around there, but if we have negative margins, we feel pretty good about those patients. And then again, clinical trials for stage 3 patients to try to reduce, try to downstage them, as well as decrease their risk of recurrence and improve their survival. For stage 4 disease, historically, for low metastatic burden, we have been doing nephrectomies, cytoreductive nephrectomies, radical nephrectomies, and then usually a localized resection of the mets. So as you can see from the first 3 stages, surgery is a very integral part of the management for renal cell carcinoma. It is mostly a surgical cancer, so removal of the disease with surgery is really important. When you start to get into the stage 4 cancers, now we're looking at, we need more systemic treatments. But even with that, there are a lot of ongoing studies and trials that look at resection of the metastases and how that does improve survival or improve progression-free survival, which is an important point for these stage 4 patients. Cytoreductive nephrectomy, 25 years ago, there was a large study that was done out of Loyola, still a very highly cited study, where they studied patients receiving cytoreductive nephrectomy with a certain chemotherapy, immunotherapy, versus versus the therapy alone, and they found that if you took out the primary cancer, that it improved their survival. I'll show you a study in a little bit that's sort of refuting some of that with the newer agents that we have. Biopsy is usually indicated in these patients so you can understand the cell type, and again, place these patients into the appropriate immuno or systemic therapies or targeted therapies that they'll receive, as well as for clinical trials. And then, of course, the systemic therapies can include targeted therapies such as the VEGF inhibitors like sunitinib, pazopanib. You may have heard of IL-2 therapy. That's an immunotherapy that's sort of used less frequently nowadays because of the severe side effects. But now, most recently, there's about 3 or 4 immunotherapies that have come out that have shown really good outcomes in these patients with stage 4 disease. Regarding the subtypes of renal cell carcinoma, there are numerous subtypes. The majority of renal cell carcinomas are what you'll hear about being clear cell renal cell carcinoma. They make up about 70% of all renal cell carcinomas. 50% present as stage 1 and stage 2, so localized to the kidney. However, almost half of them can have capsular or renal vein invasion or lymphatic invasion. The most common sites of metastases for renal cell carcinoma, and most of them being clear cell, are the lungs at 75%, liver, bone, soft tissues, and pleura. So the mechanism by which they metastasize are mostly through the lymphovascular invasion. So these cells present in the kidney, they invade into the veins that drain the kidney. That vein drains into the renal vein, which then drains into the IVC, which goes to the heart and then spreads to the lungs. So these cells go from the kidney directly through the vascular system into the lungs or the pleura, and that's how they can spread. And that's why the most common site of metastases is lungs. Again, one of the reasons for liver is through vascular invasion. Multilocular cystic RCC, these are, and I'm going to go over the Bosniak system and renal cysts a little bit later, but these are multiseptated cysts with clusters of cancer cells. Now, usually these cells are a single monolayer of cells within these cysts that line the cysts. And they have excellent prognosis after excision. They're usually low grade, so these tumors and cancers are not high grade, and there's really no risk for metastases or recurrence. So if a patient has a cystic renal cell carcinoma, we resect it, they have a very good prognosis. Papillary renal cell carcinoma, it's the second most common. 10 to 15% of patients present with papillary renal cell carcinoma. It commonly affects end-stage kidney, so chronic kidney disease patients. It's usually low stage. There are two types of the cancer. There's type 1 and type 2. Type 1 is less aggressive. Type 2 is certainly more aggressive and has higher risks of recurrence. And the 5-year recurrence-free survival, you can see that because it includes the type 2 in this grouping, there can be from 49% to 84%, depending on the subtype of the papillary renal cell carcinoma. Chromophobe renal cell carcinoma is the third most common. We're dropping off now. It only makes up about 5% of renal cell carcinomas. Most are favorable, low grade, low stage disease, 86% of them, and most of them have favorable prognosis with local resection. Collecting duct carcinoma, and there's a whole slew of others that make up for less than 1%, and then there's probably about 10 other subtypes of renal cell carcinoma that we can go over. These subtypes can be much more aggressive. 33%, a third of patients present with metastatic disease, and less than a third survive more than 2 years after diagnosis. So some of these more aggressive variants we'll see, and they need aggressive therapy. This is the study that came out most recently at ASCO in 2018. This was a randomized phase 3 study, and you're going to be going over this, I hope, with the chemotherapy talks, but I wanted to go over this because this is important as far as surgical management. These were patients that had metastatic disease on diagnosis. They were randomized to cytoreductive nephrectomy and systemic therapy with sunitinib, which is a VEGF inhibitor, versus sunitinib alone. These are the targeted therapies that first came out about 6-7 years ago, actually probably even more like 10 years ago now, for renal cell carcinoma. There was really no overall survival between the two groups. So what we knew of as standard of care before, where patients present with metastatic disease, we would remove their kidney and then give them systemic therapy. This trial has sort of changed that in the new cytokine and most likely immunotherapy era that we're in now, where removing the kidney may not be the best thing for these patients. As you can see, there was no overall change in survival between the two groups. So it does change the paradigm. I think there are still some select patients, and there's still a role for nephrectomy. So that role would include patients who are symptomatic from their cancer, patients who are bleeding, flank pain, anemic. Those are patients that may benefit from a nephrectomy from that quality of life standpoint. But what we're seeing here is a change in the paradigm from a survival standpoint. It may not make a difference. And that really speaks to these therapies. They're getting better to treat the systemic and the primary tumor. And so we'll see there's probably going to be more studies coming out as the surgeons are going to fight for doing more radical nephrectomies, and I think the oncologists. So we're going to work together to try to figure out the best course for these patients. I wanted to go over renal cysts. I think this is a really good slide here. I'm sure you've heard of the Bosniak renal cyst classification system. We see a lot of patients in the office that present with cysts in their kidneys, either incidentally found or they might have a hematuria evaluation and they have cysts. And there's a very durable classification system that's been at our disposal for many years, and it's the Bosniak system. So if we go up to the top left, the Bosniak 1 cysts, these are your simple cysts. They're clear fluid-filled cysts with a very thin wall. They can be small, they can be very large. You can see some simple cysts up to 10, 15 centimeters. Sometimes we've seen cysts that take up half the abdomen and may cause symptoms, so we'll treat them to at least drain them or excise them. But as far as the cancer risk, it's very low to nil. And so a lot of these patients we don't need to follow unless they have symptoms. The Bosniak 2, you can see in this diagram there's a little bit of a difference there. You can see some calcifications on the edge there of the cyst, and there might be some septation. These are thin-walled septae that may be going through the cyst, and maybe 1 or 2 exist there. And again, these are low grade. There's no malignancy risk with these Bosniak 2 cysts, and they can also not be followed. You don't need to have any follow-up imaging for these cysts. You see that white circle under that Bosniak 2. What that signifies there is hemorrhagic cysts. So sometimes these cysts can have blood that fills within them, and they could appear to be solid, and that's why you need the contrast imaging or a really good ultrasound or an MRI to show you that it's really blood-filled and not a solid mass. And so if you have a hemorrhagic cyst, it sounds scary, but again, there's no risk of malignancy with hemorrhagic cysts. The Bosniak 2F came about 10 years ago. These are slightly more complex cysts. These are cysts that have more septae within them, maybe thicker calcifications, bigger hemorrhagic cysts, and the risk of malignancy in these is only 5%. But these are cysts, the 2F, and the F stands for follow. So these are cysts that we would follow, and depending on the size of the cyst, the age of the patient, the clinical scenario, you would get imaging 6 to 12 months, and then as you show stability, you can prolong that interval for imaging. The Bosniak 3 cysts are thicker walled. You can see here on this diagram, these are sort of representative CT pictures here, or cartoons of CT pictures, but they have a thicker walled septae, a thicker wall on the edge as well. More denser calcifications may exist in these cysts. And in these cysts, the risk of malignancy is up to 50%. So for these cysts, you do want to consider resection. And so the CT scans are really very helpful in the classification, and that in turn is helpful in letting us know how to manage these patients. Moving forward, the Bosniak 4 cysts, these are again thicker walled cysts, very thick, and they could have solid masses within them, solid lesions. So you could have a very simple appearing cyst, but it has a solid nodule in it, and that's cancer until proven otherwise. So these are these types of cysts we're going to resect with either a partial, hopefully very rarely a radical nephrectomy. Biopsy of these lesions is possible. It's not always diagnostic. Sometimes because the nodules are smaller or the walls are very thin, the biopsy may not be diagnostic. And so it's tough to biopsy cysts, although it is possible. Again, just looking at these cysts again, the Bosniak 1, just to summarize, thin-walled, clear fluid. The Bosniak 2, single septation within the middle. Both of these have 0% chance of malignancy and don't need to have further imaging unless clinically indicated. The Bosniak 2Fs, there's a 5% chance of malignancy, and these are thicker walled or have more septation within them. The 3 have significantly thicker septae and thicker external wall, and then the 4s are elements of solid elements within the cystic structure itself, and there's a higher risk of malignancy with these patients. So we're going to move on to bladder cancer. A lot of you are familiar with bladder cancer and bladder cancer patients. Our nursing team DMG really helps to manage our bladder cancer patients extremely well. They're sort of on the front lines of all the therapies after we do our primary surgeries, and we'll go over that. But there's 79,000 new cases of bladder cancer each year. What many patients don't know is that it's the 4th most common cancer in men, and there's a 5-to-1 male to female ratio of incidence. Now that used to be higher, and it's actually shrinking because of, I'm not sure if it's the 70s or 80s, there was a higher female smoking and exposure to smoking, and I think that's increased the female incidence of bladder cancer as well. And it accounts for 4% of all male cancer deaths. Risk factors, so male gender is a risk factor. Age is a risk factor as well. The mean age of diagnosis for bladder cancer patients is 73, so this is an older population of patients that will develop bladder cancer. And just to give you a reason why, it's you could be smoking and have quit for 20 years, but that 20 or 30 years that you may have smoked, the genetic, the carcinogens that sit in your bladder cause genetic mutations, and it takes many years for those genetic mutations to potentially develop into bladder cancer. And that's why some of these patients that have quit or have had exposures early on in their life may still be at risk later on in life for bladder cancer. Lynch syndrome, it's a hereditary non-polyposis colon cancer. There's an association with the mutations in Lynch syndrome with developing not only bladder cancer, but upper tract urothelial cell carcinoma of the kidney. Smoking is the single greatest risk factor for bladder cancer. So patients who smoke have these, it's not only high for renal cell carcinoma, but it's the highest for bladder cancer. Workplace chemical exposure, so aniline dyes, industrial toxins, even diesel engine workers, so truck drivers, have a higher risk of having a bladder cancer. Chronic infection and irritation may also occur. So our patients that have chronic indwelling Foley catheters for many years, those that might have suprapubic tubes for many years, they do need to be screened for hematuria. Certainly the catheter may cause that, but they need to be screened for bladder cancer periodically. So sometimes a cystoscopy once a year or every 18 to 24 months may be necessary in these patients that have chronically indwelling foreign Foley catheters. And then a history of chemotherapy is also a risk factor for bladder cancer. That chemotherapy gets processed by the kidneys and it sits in the bladder, and it can cause that irritation or mutational changes that could lead to bladder cancer. One thing I didn't include here is a history of radiation therapy. So patients who've had pelvic radiation either for rectal cancer or for prostate cancer, in those patients that have just pelvic radiation for prostate cancer, I cite to my patients that there's a 10 to 15% risk of having a secondary malignancy because of that radiation therapy. So pelvic radiation history is another risk factor for bladder cancer. Signs and symptoms, the most common sign is gross hematuria. Rarely we'll diagnose patients that have microscopic hematuria, but as you know, a lot of microscopic hematuria workups are not for cancerous reasons. The incidence of cancer for that is less than 1 to 2%. But dysuria, irritative voiding symptoms, changes in urination, frequency, urgency, and usually for a more advanced disease, flank pain or lower abdominal pain may be a sign or a symptom. The diagnosis, as you know, the mainstay diagnosis once you have a patient with gross hematuria is office cystoscopy. It really takes about 30 seconds in the office to look inside a patient's bladder and diagnose them with a tumor within that bladder. Sometimes we can biopsy those patients in the office for diagnostic confirmation. I tend not to biopsy a lot of my patients in the office because a majority of them are going to have to go to the operating room for TURBT, and therefore I don't necessarily feel that it's needed. But in certain patients, you can do it to resect or to look for CIS, and so that is an indication. And then upper tract imaging is very important. So if these patients present with gross hematuria, you do want to get a contrast-enhanced CT scan of their kidneys to look at the kidneys, the ureters with a urogram. And if you can't do that, sometimes in patients with chronic kidney disease, at the time of surgery when you go to the TURBT, to do retrograde palograms is important to examine the upper tracts. And then urine cytology, we also use that for diagnosis as well. You may have seen these pictures. These are what bladder tumors look like on cystoscopy. These are papillary tumors here. They have a fibrovascular core, so the little red spots are blood vessels that are feeding these cancer cells. They can show up like this as papillary growths, almost like coral reef. They can show up as flat carcinoma in situ, or it looks like an irritative red type of irritation that would need to be biopsied. And they can also show up as large pedunculated solid masses, and sometimes the higher grade tumors show up as that. You can map these tumors out on cystoscopy, and then certainly when you go to the operating room, you're going to do a much more thorough look and resect all the disease. One of the newer NCCN guideline indications is blue light cystoscopy. So this has been studied over the last 5 to 7 years, and what we see with blue light cystoscopy is this is a photodynamic detection of cancer. So what we see with the white light might be in that center, that left-sided picture is just a red irritative spot. But when you give the cis view and this photodynamic molecule, it basically binds to more active cells, and it can produce photodynamics, which you can see with the blue light, and you can detect it shows up as pink on cystoscopy. So now what you thought may have been a suspicious area, you can see it lights up, and you can clearly biopsy and clear that area of the pink at the time of your TURBT or your biopsy. So this is more up and coming. A lot of the community practices are starting to use this now as well when they take patients to the operating room. Just to go over some of the results with blue light versus white light. So hexoaminolevulinate is the molecule. It's also known as cis-view. This is an agent, about 50 cc's is placed in the bladder through a catheter about 1 hour prior to the scheduled procedure. It does absorb into the cancer cells, or they're more rapidly active cells. And the photodynamic detection is used with the blue light, and that's why it shows up as pink within the cystoscopy. So it's almost like an imaging study as well. And the recent multi-institutional results, this was a 749 patient study that was done across the country, mostly academic centers. The detection of any malignancy was increased and improved with using cis-view and blue light, 91% versus 79%. Even the flat lesion detection was improved. So these are lesions that we may think of as irritative findings on cystoscopy, but they show up and they light up using the PDD, and there was an increased detection rate with that. So overall, using PDD and blue light in patients has improved our cancer detection rates with these patients, and this is a newer addition to the NCCN guidelines. Resection of the bladder tumor is done through transurethral resection. It's a cautery loop. We tend to use a lot more bipolar cautery now than monopolar in the operating room. There's a better cutting through it, and it's better cautery as well. And it doesn't spark into the obturator nerve, and so that's a helpful thing as well. But the idea of resecting a bladder tumor is to get two things from it. You want to know the grade of the cancer, and in bladder cancer there's only 2 grades, low grade and high grade, and you want to know the stage of the cancer. So we're going to go over staging in a little bit, but that stage is important to know the depth of invasion. So with bladder cancer, there can be depths of invasion, and you can see at the lower bottom half of the screen, oh, thank you, is flat lesions. These are known as carcinoma in situ. This is also known as T0. You can have papillary lesions that are just on the surface of the mucosa, and those are TA lesions. They're in the superficial mucosa. If they invade through that mucosal layer into the submucosa, they're known as T1 tumors, and these are a slightly higher grade. T2 tumors, number 4, there is now invading into the muscle, the superficial muscle, or number 5, which is the deeper layers of the muscle. That's the detrusor muscle that helps contract the bladder, and that's stage 2 disease. And then as you go to a higher, more advanced disease, number 6, it's going into the fat surrounding the bladder. Number 7 is then going into outside of the fat and into the surrounding structure. So in this diagram, that's the vas deferens or the seminal vesicles, or 8 directly invading through and through the bladder into the prostate, and that's a T4 disease. So just another diagram going over the staging again. T0 is that superficial flat surface tumor, carcinoma in situ. TA is on the superficial surface, and then you get into T1, which invades into the deeper submucosal layer, T2 into the superficial muscular layer, T2A, and then T2B is into the deeper, T3, and then T4 as it advances through the bladder into the adjacent structures. I draw that red line there because everything above that red line is considered or known as non-muscle invasive disease and has implications for management as well as prognosis. And then everything below is known as muscle invasive disease, which again, that's an important distinctive line. And I show this on a diagram for my patients all the time just to let them know the importance of that staging. And that's really can only be done through a TURBT. There are studies being done whether MRI can help diagnose these patients better, not better, but even helpful. But it's really the TURBT that's most important. Getting that tissue, having that surgery is important. You can see here stage of diagnosis. A majority of bladder cancer patients present with localized disease, which is good news. So about 70% of patients, as you can see on the diagram, present with localized disease. Regionally advanced disease is about 30%. So I tell my patients there's a 70-30% chance that you're going to be in the localized disease, have non-muscle invasive disease. There's a 30% chance at presentation you might have muscle invasive disease or beyond. And so a lot of the lower stage localized disease, they can be treated locally with bladder preservation. Once you get into the T2 and above, there's now a multimodal approach to therapy there, and we'll go over that with neoadjuvant chemotherapy as well as consolidation surgery. So just going over the American Cancer survival rates, survival rates, all stages, 5-year survival is 77%. 10-year survival with bladder cancer is 70%, 15-year survival is 65%. That sounds really good because it's taking in all stages of disease, including that 70% that has non-muscle invasive disease, and we know those patients do well. But survival by stage, you can see the differentiation there. The 5-year survival by stage for stage 0, that's your localized TA disease, is 98%. Stage 1, which is T1, is 88%. Stage 2 drops down to 63%. Stage 3 is 46%, and then metastatic disease or stage 4, the survival rate is 15% for 5 years. So it's significant drop-offs there once you start going beyond the muscle invasive and beyond. So for the NCCN treatment guidelines for non-muscle invasive disease, for TA low-grade cancer, you can observe a lot of these patients. Cystoscopy rates can also be, for surveillance, can be prolonged intervals, and then intravesical therapy may be used in these patients, either a single agent, mitomycin, or a 6-week course of mitomycin or gemcitabine can help reduce the risk of recurrence for these patients. In general, low-grade bladder cancer patients do well. For high-grade superficial or TA disease, we can repeat the resection if we feel that we didn't get it all, or if there's no muscle in the specimen. So it's interesting when you look at this recommendation, this is disease that they saw was superficially invasive. So it was actually not superficial, it was just on the superficial layer. But if you don't get muscle, we would still recommend going back and doing a restaging TURBT. And even if that's negative, that's great. But you want to ensure that the surgical resection is done completely, and that's really an important part to all bladder cancer. We'll go over things like BCG intravesical therapy, but these therapies don't chemoresect. There's not a lot of resection for a tumor, so BCG doesn't substitute for a poor TURBT or an incomplete TURBT. If you haven't resected all the tumor, that is really important to do before these therapies are given, because these therapies are meant to reduce the risk of recurrence, not to treat the patient to kill that tumor there. So it's just an important point to make, and especially if they have a higher tumor burden. For TA high grade, observation depending on their side effect profile or their age can also be used for TA high grade tumors. When you have T1 high grade, most T1 tumors are high grade. In the past, you might have seen pathology reports with T1 low grade, but by definition, if it's invading into that submucosal layer through the basement membrane, that's a high-grade cancer. A restaging TURBT is always indicated in these patients, so it's invading into the submucosa. You may have felt that you got it all the first time, but because it's T1 high grade, going back and resecting more is important. Even if you're just resecting the scar or the areas around the scar, it's really important to go back and resect those cancers again. And I tell my patients all the time that yes, we feel like we got it all, but we need to go back and make sure and just resect the surrounding areas, because that does reduce the risk of recurrence and help with all the other therapies subsequently. In certain patients with high volume T1 high grade cancers, cystectomy is indicated, so we can select certain patients to go directly to cystectomy. And the reason is, when we do cystectomies in certain patients with T1 high grade, there is a 15% chance that they could have lymph node metastases. So these cancers, again, are invading deep into the submucosal layer. There are lymphatics there, and they can escape through those lymphatics into the regional lymph nodes. If you do a restaging TURBT and there's no evidence of disease, BCG intravesical therapy is indicated, as well as if they can't tolerate that, intravesical chemotherapies, either with gemcitabine or mitomycin. For recurrent disease, we recommend repeat TURBT, additional intravesical therapy with either BCG induction or intravesical chemotherapies or BCG plus interferon. There's a whole slew of therapies that we can give afterwards. And then in certain patients that have recurrent cancer that's T1 high grade that continues to come back, early cystectomy is an indication. For stage 2 disease, this is now the muscle invasive patients, the muscle invasive cohort. Now we're getting into that multidisciplinary approach to these patients. So for stage 2 disease, it's muscle invasive. It still may be localized to the bladder, but neoadjuvant cisplatin-based chemotherapy plus cystectomy is the gold standard for these patients. But there are other options and approaches that you have as well. So neoadjuvant cisplatin-based chemotherapy plus a partial cystectomy in certain select patients. So those are patients that have a single localized tumor, usually lateral wall or anterior wall, that we can resect either robotically or with open surgery. But they would get chemotherapy first, then have that resection with a lymph node dissection. And then certain patients may not be eligible for chemotherapy. They may not be eligible for cystectomy or surgery, and those patients would have chemoradiation. For stage 3 disease, we're now looking at neoadjuvant cisplatin-based therapy plus cystectomy plus potentially adjuvant therapy with either radiation therapy or additional chemotherapy, and now additional immunotherapy is indicated in certain select patients. Moving on to BCG therapy, as you may all know, it's immunotherapy. BCG is Bacillus calmette-guerin. It's a vaccine that's used in numerous other countries for tuberculosis. So it is the TB bacteria. It's an attenuated mycobacterium. It's administered intravesically once weekly for 6 weeks. That's the induction therapy. And it's usually started 4 to 6 weeks after TURBT. The reason you want to wait that long is so that the bladder heals. And so there's less likelihood of absorption of that BCG into the system and then having a systemic response from it. We give typically induction therapy, and for high risk or high grade patients, we want to give maintenance therapy, and that's 3 weekly installations at 3 months, 6 months, and then every 6 months thereafter for about 3 years. Now, there are different methods of maintenance therapy. This is the most widely used. This is based on a SWOG trial that was done. But some patients, some doctors I've seen, and some in Europe and other places are using monthly installations, and so there are different ways to do maintenance therapy. The mechanism, there's a broad studies on how the mechanism of BCG works, but it basically activates the immune system within the bladder. So these patients have the bacteria placed in their bladder. There's an immune response to the bacteria within the bladder, and that activates the immune system to bladder cancer cells that may be present within the bladder wall as well. So in general, BCG intravesical therapy reduces the risk of recurrence in patients by 50%. So it is indicated for all high-risk patients and maybe even certain low-risk patients. As you know, bladder cancer, the recurrence rate is about 70% over 5 years. So a patient who has a bladder cancer resected, they might have it come back at a rate of 70% over that 5-year period. So reducing it by 50% is huge. Some of the complications of BCG, this is where our nursing team is vital and key. They're the ones that are seeing these patients on a weekly basis, treating them for their BCG. 62% present with local symptoms, and it's the method and mechanism of how it works. It's going to cause irritative voiding symptoms. It's going to cause potentially hematuria, dysuria, frequency, urgency, and they do subside over the subsequent weeks, as you know. 30% may present with systemic symptoms. Now, that's in the literature, although I think in our patient population that we have at DuPage Medical Group, we don't quite see the same 30% rate of systemic symptoms, right, guys? It's not that high with what we see. Local side effects are 35%, and this is based on the literature of cystitis or bacterial infection at 23%. Systemic side effects can include general malaise or fevers. It's a much lower percentage, but any itis, so prostatitis, orchitis, epididymitis, these are all side effects. And then certainly much more, you can have gastritis, and that's more systemic side effects as well from BCG. And we're fortunate in that we do not see those major systemic side effects in our patients today. But ways to reduce the side effects or avoid those side effects is prolongation of that time from resection of the tumor to the BCG administration, and letting that bladder heal is important. So having someone that's had a TURBT for a 3, 4, 5 centimeter cancer and then sending him to our nurses to say he needs BCG induction within 2 weeks is probably not a good idea. There's still healing from the bladder. There's still probably exposed mucosa and blood vessels, and they could have more systemic side effects as well as significant local side effects. Lowering the dose by a third or a half has been shown to be effective in reducing side effects in patients, but there are some studies that show with certain high risk or high grade patients that might not be such a good idea because it may decrease the efficacy to prevent recurrence. So I think in my opinion, giving some is better than giving none for these patients, especially if they can tolerate it better. So we reduce the dose, usually is by 50% in our practice. Treating with antispasmodics, so your oxybutanins, ditropans, detrols, has really been studied, and it's not necessarily effective by giving them a couple of doses around the time of the BCG to help them with those symptoms. And instead, it can actually increase the side effect profile because some of these drugs have more systemic side effects in these patients. So it's not really effective or indicated. And then tuberculostatic drugs like rifampin or isoniazid have not really been recommended around giving them around the time of BCG to reduce the side effects. Again, these are things that have been studied but are not recommended and usually don't help and may actually render the BCG ineffective. So for patients with more advanced disease, T2 and beyond, stage 2 and beyond, radical cystectomy is indicated. What you can see in the male is that we remove the bladder, the prostate, a portion of the ureters, and we do an extensive lymph node dissection. In females, it's the uterus, ovaries, bladder, as well as the fallopian tubes and a lymph node dissection. And in some cases, the anterior vaginal wall is resected as well. In certain patients, we might preserve that vaginal wall for patients, especially if they're younger. We can do that surgically. So when you have a radical cystectomy, the ureters have to drain into something. And so really there's two main types of diversions. Your incontinent diversions, which a majority of patients receive. And the main reason a majority of patients receive this is that they could be more of the elderly population. So the maintenance for ileal conduits is much lower than your maintenance for a continent catheterizable diversion or a neobladder. And what I mean by that is these patients don't have to use catheters. They don't have to catheterize intermittently or catheterize their bladders to drain them. Sometimes in women, there's a higher retention rate with the neobladders. And so these are really the two types of diversions that are done. In our practice, really 95% of our patients that undergo radical cystectomy are going to have a ileal conduit. And I think Kathy's going to talk more about pouches and stuff, so I didn't move on with that. But there are a lot of complications to radical cystectomy. This is probably the most complex surgery that's done in urology today. And you can see in this study here by the NIH, the rate of any complication, it's higher than 50%. I quote 60%. Now, a majority of the complications that we see are mostly bowel related, so ileus or a prolonged ileus where they have nausea and vomiting after surgery, and that's considered a complication after surgery. But you can see here by the NIH review of national data, the risk of blood transfusion after surgery in hospital is almost 40%. Post-operatively, when they go home, it can be as high as 10%. DVTs, up to 5% of patients can have blood clots in their legs develop. Sepsis, up to 10%. UTIs, almost 10%. Surgical site infections, between 7 and 10%. So this is the reason for these complications. You can say, well, why do we do this surgery? Well, it's not necessarily the surgery. It's a combination of everything. These patients, as you know, are elderly. A lot of them have undergone neoadjuvant chemotherapy. So these cisplatin-based chemotherapies, they cause immunosuppression, they cause bone marrow suppression, so you can have anemia, a weakened immune system. So your risk of having infection is higher in these patients. They're starting out anemic, so that's why the blood transfusion rate may be higher. And then some of these patients, they don't have the nutrition because of the chemotherapy, so they're weakened from the nausea and the vomiting, and so they don't have the most optimal nutrition, and that can lead to surgical complications as well as ileus postoperatively and infections. So pretty high complication rate in these patients, and this is what we cite to our patients afterwards. But there are ways to improve this, and one of the ways that we've found is doing robotic radical cystectomies. You can see here, this was when I looked it up in 2016, so it's a little dated, but in Chicagoland, there were about 580 cystectomies done in this region in 2016, and only 53 were done robotically, and that made up for only 9% of these surgeries. In our practice, 99% of cystectomies are done robotically. The NCI data between 2010 and 2013, a little bit older, but over 9,400 patients, only 34% were done minimally invasive techniques. Now, a lot of that was laparoscopic approach, and it did increase from 26 to 39% during that time frame, and I think it's increased even now in the region here. But is it better? Does it help? And why do we do a majority of our patients, despite chemotherapy, despite their age, why do we do robotic cystectomies in our patients? Well, there is studies that have been done. There are studies that have been done on this, and they're a meta-analysis of 4 randomized clinical trials. So it's hard to do surgical randomized studies because you're randomizing patients to one surgical therapy versus another. So patients may not want to join those, but we've had at least 4 studies. You can see the low numbers there, 239. 3 were in the US and 1 was in England. And they all had an open incision for the urinary diversion. There was certainly significantly less blood loss in the robotic cystectomies by about 250 cc's. That was based on this meta-analysis. And however, the operating time for robotic cystectomy was a little bit longer, almost an hour and 15 minutes longer for robotic cystectomy. So longer operating time, but certainly less blood loss. And then lower wound complications were noted. Not having an open incision that's retracted for 3 to 4, sometimes up to 5 to 6 hours with open cystectomy does provide a benefit. And there was lower wound complications with these patients with robotic cystectomy. And these are in randomized clinical trials, so phase 1 or level 1 studies. You can see a more updated study here. This is the top graph, and this is a busy slide, but you really want to look at that forest plot that's on the right there. The top one is 30-day complication rates, overall complication rates, and the bottom one is your 90-day complication rates. And if it shifted more towards the left, that means there's a benefit to robotic cystectomy over open cystectomy. And you can see the 5 or 6 studies that they have there that they used for the 5 studies that they used for the meta-analysis, both of them for 30-day and 90-day complication rates was much less doing robotic cystectomy. So again, if you ask me in my practice, why do we do robotic cystectomies? It's because we see the benefit in our patients, but we're also seeing the benefit nationally or even globally in patients with the complication rate. And if you go back and reference that first slide that I showed you, to have a 60% complication rate from a surgical procedure that needs to be done in these patients with cancer, it's pretty high. Whatever we can do to reduce that complication rate, improve their length of stay in the hospital, reduce their risk of blood transfusions, and get them back on their feet and return to convalescence sooner, that's what we're going to try to do. And so that's one of the benefits of robotic cystectomy that I see. This doesn't come alone. It's not only the surgical procedure that helps reduce the risk of complications in patients. A lot of you may have heard of enhanced recovery after surgery, so the ERAS protocol, and this is integral for our approach to our patients. It's a multidisciplinary approach involving surgeons, anesthesiologists, nurses, dietitians, physical therapists, nutritionists, and it's one of the key paradigm shifts that's now needed to optimize recovery in our patients. And it's used initially in a lot of colon cancer studies. That's where the enhanced recovery came about. But urology quickly adopted it for our radical cystectomy patients because it's super important. And I'll talk to you about our approach that we use, but this is sort of the framework here. It's not just after surgery that's important. Everything before surgery is important as well. So in the preoperative setting, patients need to be counseled, and we have an MP that sits down and goes over the procedure with these patients. These are patients that are going to have neoadjuvant chemo and radical cystectomy or radical cystectomy alone. And there's teaching with verbal and written instructions. Expectations are set with the patients. Again, we go over the risk of complications, the hospital stay, the prolonged recovery that they may have. There's a discharge plan set in the preoperative setting. There's also, in our group, we work with a home health nursing team that sees the patients at home, assesses their nutrition there, and also does the stoma marking at home. So these patients don't have to make multiple trips. Of course, these patients have had chemotherapy. A majority of them have had chemotherapy before surgery. They're tired, they're weaker. We want to make sure we can optimize things for them and make it easier on them. So medical optimization of the lungs, cardiac optimization, prehabilitation is important. These patients may be weaker, and giving them PT even before surgery can help their recovery after surgery. As most of you know, surgery in general is like going through a marathon, and so training for it or getting optimized for it, even physically, is important, as it does take a toll on the body. And the nutrition is important as well. Getting these patients on protein or boost shakes before, especially if they've had chemotherapy, if they've been nauseated and they're weaker, if they've lost weight, we want to make sure their albumins and their weight is coming back up prior to surgery. We don't do any prolonged fasting or even major bowel preps anymore with our cystectomies. Even when doing it robotically, we don't have them go through any go lightly or major bowel prep. It's usually just clear liquids the day before, and then a carb loading as well. And then there's no bowel prep, and then certainly blood thinning. Preoperatively, we do, because they have a higher risk of DVTs with the chemotherapy as well as the cancer risk, or the cancer that they have, we give them blood thinners before surgery. During surgery, we work with our anesthesiologists, our preoperative nurses in pre-op to avoid fluid overload status, maintain normothermia. We give as much local anesthesia as we can. In our patients, at some of our hospitals, we give IV lidocaine. The anesthesiologists are willing to do that to help reduce the risk of the use of narcotics after surgery. Postoperatively, pain control is important. We want to avoid opioids, the toxicity of them, plus the bowel side effects that opioids have. Early mobilization is important. Some of these patients went through prehab, and now they're meeting with the same PT specialist for PT in the hospital. Early mobilization. Am I okay on time? Is that? Oh, okay. Oh, good. Okay. And then early oral nutrition. We used to, when I was at Cleveland Clinic, we used to keep these patients MPO for almost 48 hours. And now throughout all surgical specialties, that's really changed. There's no reason to keep them MPO or malnutritioned for that long. So we're giving them liquids early and then full liquids and advancing them even to regular diets by 48 hours afterwards. And if some patients regress, we manage it. It's not so terrible. Sometimes they need just a slightly more MPO or clear liquids. We try to avoid NGs in these patients. Usually they'll have OGs in surgery, but then they're removed. And then prevention of that nausea and vomiting with medical therapy. And then, of course, all of them need blood thinning, either through heparin or Lovenox. Either they're going to need it during their hospitalization, and then we keep our patients on blood thinners for up to a month out after surgery when they're home. So they'll either give themselves the injections, or home health or their family member will give them injections, because the DVT rate even afterwards is quite high. So if I was running late, I'm finished now, so I'm done. So hopefully that was good. I want to thank you, everyone, for being here. It's great to be here and present to urology nurses. It was a pleasure. Thank you.